And I will, I do have kind of a blurb here that I'm saying at the start, so got a couple more minutes. Anna, are people able to join? Does this mean we don't have anybody joining yet?
I'm seeing about 150 people joining. So
thank you. I was looking at the wrong thing. Oh, hello. Welcome, everyone. Sorry about that. I'll maybe give one more minute and then we'll get started. Okay, welcome on this chilly Friday to the Social Workers Confronting Racial Injustice Conference. I'm Angela Willits, and I'm really happy you're all here for this breakout presentation on Madison Cares, the crisis response team. A visual description of myself: I'm a fair-skinned, middle-aged white woman with brown hair and a ponytail, blue eyes and brown glasses, and I'm wearing my favorite yellow dangly earrings and a brown sweater. Just so you know, we are providing live captioning CART services, which are available by clicking the captioning icon. This presentation is being recorded and will be available on our conference website soon. Now for a land acknowledgement. On behalf of the Planning Committee for the Social Workers Confronting Racial Injustice Conference, I ask that you join me in acknowledging that our University of Wisconsin-Madison campus here on the shores of Wangshik-Hom Ikla, or Lake Mendota, resides within the sacred homeland of the Ho-Chunk people, a place they call Dejop, or Four Lakes. As the reach of the university extends to the far corners of our state, we also respectfully recognize the inherent sovereignty of the 12 First Nations of Wisconsin. Whether you're watching this from the land of these 12 First Nations or you're more distant, we encourage you to learn about the history of the land you are on. As social workers, we have a duty to look critically at the role of our profession that it's played in the attempted cultural genocide and destruction of Indigenous families, such as was the aim of boarding schools in this state and across this continent. This conference is rooted in critical reflection on our work as social workers. Our goal is to bring clarity about the past, but also to challenge and inspire us all to move into action in our work in communities once this conference is over. We hope this conference provides space for critical reflection, humility, and openness, which will allow us all to reflect, to hear truths and tell truths, and move toward action and transformation to support Indigenous rights, cultural equity, and racial equity. With acknowledgement and gratitude, we move forward today in our journey. Before I introduce our speakers, I wanted to give a few Zoom info items. To access this presentation, you are required to provide your name and email. This allows us to log our attendees and email you information on CEUs for this presentation, which will be distributed via email at a later date. Your cameras and microphones will remain muted. We do have the Q&A feature, so not the chat, but Q&A, where you can submit questions for our presenters. Please know that with the large volume of attendees, we'll do our best to get to all of the questions. And there's no need to ask questions about CEUs or things pertaining to the conference. If possible, if you can go to the Eventbrite page or the conference website to answer those questions. Now it's my pleasure to introduce you to our presenters. Sarah Henrickson is a licensed clinical social worker and clinical team manager with Journey Mental Health's Emergency Services Unit in Dane County, where she oversees crisis workers embedded with first responder partners, including law enforcement and the CARES team. Stephen Button is a community paramedic for the City of Madison Fire Department's CARES team and has over 13 years of emergency medical service experience. Olivia Kostreva is a licensed professional counselor in training and works as a crisis counselor on the CARES team. Ché Stedman is the Assistant Chief of Medical Affairs for the Madison Fire Department and oversees the CARES team. He's been a member of the Madison Fire Department since 1996. And Carla Williams is the program supervisor for the Lutheran Social Services Off the Square Club, which is a mental health day center that works with adults in Dane County. Welcome to all our panelists. Thank you so much for being here, and I will mute myself and turn it over to you.
All right. Thank you, Angela. Again, my name is Ché. For our folks that can't see me very well, am a 52-year-old white male with a military-style haircut and a white Madison Fire Department uniform shirt. Pleasure to be here. I'll let Sarah introduce herself once she starts speaking. So what we're going to do is I'm going to share my screen. We've got just about like 20 slides to go through. I'm going to present about half of them. Sarah will present the other half. And then Steve and Olivia are here as team members to help answer your questions at the end. So hopefully our presentation won't take too terribly long, but we'll have a lot of good conversation. So I'll go ahead and share my screen. And make sure everybody can see that okay. Good, Sarah, good. All right, so our crisis response team in the City of Madison is the Community Alternative Response Emergency Services, or CARES team. And so for a little background, I'm sure this is well known to everybody, but historically, the City of Madison's mental health crisis response model has been driven by the law enforcement community. In 2019, the Madison Police Department estimated that it received approximately 7,000 calls for service related to mental health crisis. And when we researched the kind of the national best practices around mental health response, the model that we found to be most patient-centered was certainly one that incorporated unarmed first responders with mental health providers. So the other models that we looked at, and we actually looked at probably close to 10 models around the country, but the two main models that we looked at were the CAHOOTS model in Eugene, Oregon, and they've been in service for at least 3 decades, a little bit more. And then the STAR model, the support team assistance response model in Denver, Colorado. And this is a little bit more similar to what we're doing because it's a fire-based community crisis response team. We spoke with San Francisco, Austin, Texas, and a number of other cities around the country that were running successful programs. So what we were tasked with from the mayor and the city council was to develop a mobile crisis response team to respond here in Madison to a wide range of nonviolent mental health crisis, with the goal to ensure that medical and behavioral health care is integrated from the onset, right? It's about having the right intervention at the right time, having those crisis workers be the first folks that walk through the door when somebody calls 911. So this helps not only increase patient satisfaction, but we're diverting people away from law enforcement and away from emergency rooms if they don't need to be there. So just to give you an idea of how much time this took us, in summer of 2020, one of our alders here in Madison, Arvina Martin, came to the fire chief with an idea about developing this crisis response team similar to the CAHOOTS model. In November of 2020, we had the support of the city council, and they approved the initial funding for our first team and for the first year of our team's progress. And in June of 2021, we started hiring the workers. So the fire department started hiring some community paramedics for the team, and Journey started hiring their first set of mobile crisis workers to work specifically with CARES. And it's important to mention here that there's actually a state administrative code coming from the Wisconsin DHS. It's admin code 34 that actually speaks very specifically to mobile crisis response in the state of Wisconsin. And what it does is it gives the statutory authority for any mobile crisis response team to each county in the state. So our first call was to Dane County Human Services, and they were luckily very agreeable and were willing to work very closely with us on this, and they've been involved since. But Journey Mental Health has a contract with the county to provide crisis services for the county. So because of that relationship, we work with Journey Mental Health as well. So just to get into a little bit of the technical stuff, the Madison Fire Department has a contract with Dane County Human Services. We pay Dane County Human Services for the Journey crisis workers' salaries and benefits. And then we have a memorandum of understanding with Journey Mental Health as far as the services that they're going to provide. So this is, in my opinion, between the Madison Police Department, Madison Fire Department, Dane County Human Services, Journey Mental Health, the Dane County 911 Center. This has been really well done intergovernmental relationships, working with partners in the community. Being a firefighter for 28 years, I've seen a lot of barriers to relationships like this. So things have gone really well, and it's because we've been supported so well from the community. So that's kind of how the planning began. And then it took us until September 1st of 2021 to actually put one team in service. And the program started as kind of, we did things in phases, right? We wanted to make sure we were doing things right. We wanted to make sure we were looking at data, doing things that were under best practices. And so when we started September 1st of 2021, we were working Monday through Friday from 11 a.m. to 7 p.m. And we were working in the Central Police District. And the reason for that is that we looked at 2 years worth of police department data. We looked at 2018 through 2020 and found that the busiest times of the week for crisis response coming through 911 was Monday through Friday. It was actually 10 a.m. to 8 p.m. So to make this an 8-hour day for our folks, we started 11 a.m. to 7 p.m. And the Central District in Madison is our downtown area. So it covers kind of a lot of the isthmus in downtown. Was by square mile the busiest geographic location for these types of calls. So we started only responding in that Central District, and our team was responding out of Fire Station 3, which is on Williamson Street. So this is our first team, 2 paramedics and 2 crisis workers, and they were responding in a minivan. And as you can see, they're not wearing, fire department uniforms. They're not wearing any sort of badges. We did a lot of community listening sessions around this stuff, and we were reminded that, coming in a little softer is much better, right? I mean, no matter how good a police officer is at their job, the fact that they walk in with a weapon on their hip and a badge on their chest can be very escalating for people. And we wanted to be the opposite of that. And also, we weren't using an emergency vehicle when we first started out because we had that kind of small geographic location. This minivan really got us to where we needed to be, and it was appropriate to help transport people to resources. But once we started responding citywide, we recognized the need to have an actual SUV that was a fire department branded emergency vehicle. So in order for CARES to get from Willie Street in the downtown area out to the far west side of Madison, it was just taking them too long to respond to a 911 call on this van. So we had to upgrade them to an emergency vehicle. But we're very cautious about the use of lights and sirens once we get close to the location. So again, so that we don't escalate that person that's having some sort of behavioral health crisis. Our phase 2 expansion, we started responding to calls citywide December of 2021. So we realized after about the first 3 months that we had capacity to respond outside of just the Central District. We got a second team hired and trained in July of 2022. We added the second vehicle. We found a second location for the second team. It's at the former Town of Madison Fire Department station on Fish Hatchery Road. So this gave us a team on the near east side at Station 3 and a team on the near kind of southwest side at the Town of Madison station, so we could have better coverage throughout the city. And we're currently running Monday through Friday, 8 a.m. to 8 p.m. So with those 2 teams running at once, we can cover more hours of the day. And our next expansion is to move into weekends here at the end of the first quarter of 2023. And so this is the fire department SUV that they respond out of now. And right now we have 4 community paramedics and 4 crisis workers from Journey working on the team. And Sarah, this is where I'm going to let you take over. Sarah's going to talk a lot more about the actual calls themselves and how we operate.
Good afternoon, everyone. I'm Sarah Henrickson. I'm with Journey Mental Health. I have over 20 years experience as a crisis worker, and I'm really excited to be a part of this amazing new initiative in the city of Madison. For a description for those who need assistance with visualizing me, I'm a white middle-aged woman with long curly brown hair and wearing a very warm orange sweater. So just to talk a little bit more about what the operations of CARES looks like, again, we envisioned this as an alternative, an expansion of the continuum of emergency response services for people calling 911. Our 24-hour crisis unit at Journey has existed for many decades, but people don't always know about our service or know how or when to utilize it. Many times calls to the 911 center might be from, family members, loved ones of someone in a mental health crisis who don't know where else to call, or the person in crisis themselves that doesn't know where to get help. Or it could be, a citizen in the community who just sees a person that looks like they might need to be checked on or be assisted in some way. And so, as Ché said, we have, and I would argue not just in the city of Madison, but across the country, way over relied on law enforcement to be our primary response to behavioral health emergencies. And so the goal and the vision for this program is to provide another response within the continuum of emergency response that can be dispatched by the 911 center. So call takers in the 911 center are trained to, they have a kind of a flow that they go through, screening questions that they ask. And whereas in the past, their options were to dispatch any or all of police, EMS, or fire, now they can also add CARES to those options of who to send to a call. So the focus is really on nonviolent behavioral health calls for service, as well as, check welfare type calls, which might be somebody who needs to be checked on and we're not sure exactly what the problem may or may not be, like someone who can't be reached by people who are concerned about them, things like that. So it really gives us kind of a broad call type that CARES could potentially be dispatched to. And so in order to ensure the safety of the team, the safety of the community, and the appropriate mission of the team, there are some kind of rule outs for these calls that the dispatchers are looking at. So if the incoming information on the call includes weapons that are involved in the incident that's occurring, or other types of violent behavior, or perhaps if there's sounds of an active disturbance that sounds like it might be unsafe, if there's a crime being reported, or sometimes it might just be a call that CARES doesn't have the resources to assist with, even though it appears to be an appropriate call type. So for example, a person who perhaps has made suicidal statements and can't be located and their phone needs to be pinged, that's something that needs to involve law enforcement. And then similarly, if a person, as you saw with the vehicle, that requires in that type of vehicle, a person who is able to be mobile enough to step in and out of a vehicle, who doesn't have a level of medical emergency that requires them to be on a gurney in an ambulance rig with the more complete complement of medical services available to them. So if any of those situations or circumstances are present, it could be that police or EMS are dispatched along with CARES. So it might be a situation where, police are dispatched, ensure that the scene is safe, and then CARES is able to come in and actually do the direct work with the patient. One kind of, I think, really positive development that I don't know how much we anticipated this is that we see the other emergency responders really recognizing when a CARES response might be more appropriate. So sometimes it might be police or EMS getting on scene with a call, and then it kind of becomes clear because based on the brief information they might have from the dispatcher, perhaps it's not totally clear what the nature of the call is or what the needs are, but as they respond and assess the situation on scene, they might recognize that this is actually something that's more suited for CARES to respond to, and they can just get on the radio and ask the dispatcher, is CARES available to come assist this person here? Sometimes that's happening even before they're arriving on scene. So for example, police officers who are getting dispatched to a call and saying, maybe, I've had previous contacts with this individual. I think that the nature of this call is more behavioral health related. So there's really been a good kind of working relationship among all these entities to recognize the appropriate resources for the call as that information is coming in. Next slide, please. So how this works in terms of operation on the calls, again, a journey crisis worker and an MFD paramedic are dispatched to every call. They carry radios and they communicate on the fire channel. So for those who aren't aware, the 911 comm center has a channel for fire and EMS and a channel for police that are separate. We're in operation from 8 a.m. to 8 p.m. Monday through Friday. Again, looking to expand into weekend hours next. So there's 2 different shifts with the overlap of CARES 1 and CARES 2 occurring in the middle of the day when the call volume is highest. The teams work 4 10-hour shifts so that they have a little buffer at the end of their shift just to complete charting and other things like that, not directly related to the calls they're on. And, as Ché said, we started out kind of small to see what that looked like with just the central district and really quickly recognized that we had the capacity to do more. And when looking at what's the best response for a call, we rely on the call takers in the 911 center to kind of calculate, this individual needing assistance might be on the far west side, and there may be a police or EMS resource that's closer, but there's nothing in the call that suggests that it couldn't wait 20 minutes instead of 5 minutes for CARES to get there, and that's the more appropriate response. So that was kind of the impetus for expanding citywide, because we'd rather have them taking longer to get to some calls than sitting idle between calls. So now we have expanded to anywhere in the city of Madison. And also, as Ché said, the vehicles do have lights and sirens on them. It's my understanding from the team that it's extremely rare for them to use those tools, that typically if that's being used, it's more just to kind of navigate traffic to speed up their time in getting to the destination, but they're never coming in hot on a scene with lights and sirens that we know can be triggering for a person in crisis and can sort of bring unwanted attention to a scene in the community. Next slide, please. So the CARES team, their vehicles are stocked with a whole bunch of supplies that are useful in helping them resolve the calls that they're on and helping them to provide assistance for people. So they don't carry any weapons or any kind of tools that are associated with enforcement. They have their medical bags. They have really just things for meeting people's basic needs, like bottles of water and snacks. They have a lockbox for, if somebody's medications need to be safely stored, we have extra boxes that we can give to people who may need them, a container for sharps. They carry Narcan and fentanyl test strips, as well as a breathalyzer. These items are not used for, enforcement purposes, but for assessment purposes. So sometimes, for example, a breathalyzer can be helpful to determine a person's level of intoxication, because that's part of the assessment of the person's medical needs. Just really practical tools like vomit bags, flashlights, safety vests in case they need, like reflective vests in case they need to be maybe interacting with someone who's in a roadway or something like that. They have binders that they keep in the car that just have information on all kinds of resources. So they have that at their fingertips if they need to utilize that to assist a person, a fire extinguisher. And for when they just need to get creative, petty cash is helpful when sometimes, buying a person a sandwich so that they can feed, when our most basic needs are met, that helps us to kind of address the other secondary needs. And if we can help someone get, a pair of shoes that they need or a meal or something like that, we want to have those resources available. Next, please. So one of the things that I think is really exceptional about the CARES team, or the design of it, is that there's really very little restriction or parameters on how they have a lot of autonomy in how they respond to and resolve calls. So for example, whereas an EMS response with an ambulance can only transport a patient to the hospital. That is the only location that ambulances can transport people to. CARES can bring people anywhere that they need to resolve a call. So some calls, they might actually just call the person. As they've been in service for a while now, they've had a number of people that they've had multiple contacts with, where they've developed a relationship with the people, and they are able to recognize when a phone call might suffice to just kind of check in with the person, make sure they're okay, give them a little bit of support, or they may respond in person to a person who's familiar to them or not, and be able to meet that person's needs through supportive listening, talking about resources they can be connected to, just helping them feel supported and cared for in the community. And they may just disengage from the person on site without taking any further action or transporting them anywhere. If they do need to transport the patient, they can, as I said, go anywhere that's needed to help resolve the call. So sometimes a person might just be given a ride home, or to the home of another person in their life, family or friend, or someone that we would do kind of a warm handoff to make sure that, they're able to be there for this person, help support them, help them be safe. Many times they're taking people to a shelter or the Beacon or other facility, to hospitals for more intensive treatment if that's needed. And also to detox. That was a kind of happy surprise we encountered really early on when CARES first launched, is that we were able to, with the support of Dane County Human Services, who adjusted their contract with detox to allow that CARES to bring patients there who are in need of being a placement at detox, but are wanting and willing to go there and don't need to be placed into police custody in order to receive those services. So CARES can transport those patients to detox as well. A lot of the work they're doing is really just connecting people to resources. It's crisis intervention, and baked into that is crisis prevention. What does this person need addressed so that they won't be in crisis in the future, or that we can kind of decrease their need for emergency response. And in the event, which has been relatively rare overall, that a person is in imminent risk to themselves or others and is unable or unwilling to participate in voluntarily accessing a higher level of care. So then when we're talking about potentially an involuntary psych hold, then staff from the crisis unit become involved at that point. This is one of the tasks that we perform in Dane County that we've been doing for decades. And we really made a very conscious decision not to have CARES conducting those evaluations because two primary reasons. One is that the whole emergency detention process is very involved and time consuming, and we want to free up CARES to get back into service and respond to other people in need. And that we wanted to really make sure that our messaging and our presentation of this resource is that it is completely voluntary. And so everything that CARES does for a patient, the patient is consenting to. So if a person, is looking, if it appears that the person needs to be detained involuntarily for treatment, we want to kind of have CARES step out and have a different resource step in to handle that situation. Next. How does CARES improve services? Well, in our first year of service, we responded to over 935 calls for service. And Ché, do you happen to know the current number? I want to say it's like 1,700, something like that.
Yeah, we're at 1,780 calls as of today.
Excellent. So every one of those calls is something that would have otherwise, if not for CARES existence, would have been handled by police or EMS, probably more often than not by law enforcement. Another statistic that we're really proud of and happy about is that only 3% of CARES patients have required police transport. So most of these are the ones I was just talking about, where it's an emergency detention and involuntary conveyance to a hospital. So the vast majority of calls have been able to be resolved without involving law enforcement. And, again, with that being the primary reason when law enforcement is needed to be involved, it's exceedingly rare. I'm not actually sure if it's happened yet at all that CARES has had to request law enforcement because their own safety was at risk. It's been more about ensuring the patient's safety. So of course, when CARES responds instead of police, there are a number of reasons why that's better. We know that it's going to be more helpful in keeping people not only out of jail in the criminal justice system, but just decreasing people's contact with law enforcement, which, even the most well-trained officer who is kind and empathetic to a person in a mental health crisis is a uniformed, armed law enforcement officer that is a representative of enforcement in the criminal justice system. And this adds to the stigma of mental illness and criminalizing behavioral health crises. So really, as a community and as a society, we should be striving to make more of a separation between those systems. It also helps to keep people out of hospitals because law enforcement officers don't have the same level of training that mental health clinicians and other professionals do in terms of responding to people in behavioral health crisis. So their officers are more likely to transport somebody to an emergency room or to a higher level of care than a team that is trained to help people resolve their crises in the field. And then just the focus on connecting people with, what a person needs, real time, real need right now. Having that response in the moment is really critical to improving people's experiences. Next. So right now we're just showing a couple of graphics that just illustrate some data from CARES. So what this shows is that the average responses per month were 40 or less for the first few months. And then after before we expanded the size of the team, but just expanded their service area to the whole city instead of just downtown, the number of responses roughly doubled. And then when we added a second team in April, the rates continued to rise. And then in July, when we expanded from 8 to 12 hours a day, we were up to an average of 142 calls per month. This is data that's from our annual report, our first annual report that was released a few months ago. So it ends with August and September showing 183 calls per month. Next. This next graphic shows the outcome of CARES calls. So the categories that are listed are, in some cases, a patient might just decline help. CARES arrives on scene and they say, I'm good, or I don't want to talk to you, or I don't need anything. That's been about 12% of our calls, again, referring to the calls for service in the first year of service. Roughly the same amount, CARES has provided support to the person by phone without necessarily responding in person, which is appropriate and okay sometimes. We want to give people the level of service they need in that moment. The top two categories are responding to a person in person, providing assistance to them, and not transporting them anywhere, 38% of calls, or transporting them somewhere, 30% of calls. So roughly 2/3 of the calls that they're going on, CARES is resolving with the patient without transferring their care to EMS or law enforcement. And those are kind of split between providing that support on scene or transporting them to another location. Next. Of the CARES patients that are transported, again, they can be taken anywhere that is needed to, that's helpful to resolve the person's crisis. So about 18% are to emergency rooms, and then just 1 to 3% to other locations like their home, directly to a psych facility, day shelters, detox, residential shelters, and other destinations. Next. So extrapolating from the data that Ché mentioned regarding the calls for service that Madison Police Department identified in that 2-year period, and then looking at the number of calls for service that CARES has gone on. So it's not exactly a one-to-one comparison because we're looking at data from 2018 to 20 and then data from 2021 to 22, but kind of comparing those data sets and extrapolating from that, we're seeing that CARES responds to over half, 57% of the estimated number of mental health related calls for service that are occurring in the city during the hours that they are in service. Next. And then lastly, just wanted to end with this testimonial. This was an unsolicited comment in a letter that was sent by family members of an individual who was in actually a series of behavioral health crises, many of which CARES responded to. And I'll just share with you what they said. They said, they, meaning the CARES team, immediately developed a rapport with our son and de-escalated an already tense situation. This was a classic example of sending the right person to the right call. It reduced trauma for both my son and our family, and hopefully reduces the frequency of his trips to seek medical care. It was very comforting to us that we had this team of experts to rely on and work with us over a couple of weeks to obtain the best support for our son. This program is very valuable in our community, and from our perspective, very needed and successful. So I think with that, what we'd like to do is have Steve and Olivia and Carla each introduce themselves and explain, give their description and a little bit more about their roles. And then we really want to spend the rest of the time just opening it up to questions and comments. And as Angela said, you can submit those in the Q&A, and we will just go through them in the order that they come and answer your questions to the best of our ability. And if there's something that we don't have the information at our fingertips or ability to answer, we will work to get that information and forward that to Angela to be shared with you. So I will go ahead and pass it to Steve.
Thanks, Sarah. My name is Steve Button. I am a community paramedic with the Madison Fire Department CARES team. Description of myself, I'm a mid-30s male, white skin. I've got jet black wavy hair, some facial hair, and I'm wearing a gray polo, which is the CARES uniform. My role on the team is to provide medical care for our patients that we meet in the field, making sure that those suffering a behavioral health crisis are also being assessed medically to ensure that their vitals are stable and their medical care is taken care of. I'll pass it to Olivia.
My name is Olivia Kostreva. I am a white woman in my late 20s, brown hair, gone for a top knot today. And we have new t-shirts, which are kind of like a light white color. Our logo is kind of cool. It's a circle with the CARES and cursive font, or the team name, and then also a stethoscope with a heart in it. And I am a crisis counselor, and I will pass it along to Carla.
Good afternoon. My name is Carla Williams. I am the program supervisor of Off the Square Club, which is a daytime resource center for individuals that have a mental health diagnosis. For visual, I am a middle-aged white woman with long red hair, blue eyes, and I'm wearing a dark gray sweater. Go ahead, Sarah.
If you don't mind, I just want to also add that we invited Carla because Carla interacts with the CARES team quite a bit. So we have these people on the panel who are overseeing the program, Ché and I, and people on the panel who are doing the direct work in the community of CARES, Steve and Olivia. But we also wanted to invite a community partner who can kind of provide an additional perspective from the consumers that she works with who have been served by CARES.
And I'm just going to jump in real quick, Sarah. Steve and I have been trying to keep up on answering questions in the chat, but we're quite a few questions behind at this point, and there were some that we wanted to talk about. And so the first question, and I just want to make sure from Angela's point of view and Anna Maria, is this a good time for us to just start going through the chat?
Yeah, this is perfect.
Okay, good, excellent. All right, so the first question I have that we haven't answered yet is, can the panelists speak to the types of calls they receive related to youth, families, mental health crises, and about the response, maybe similar or different from adults? And I'll just start by saying that when we run the demographic data for all of our calls, we see only about 4% of folks under 17. And, I personally couldn't tell you why we see a small percentage of calls for youths, but I can tell you that we do see them. So I don't know if Sarah or Olivia have any other comments on the specific types of services they receive otherwise.
So I think one of the reasons for that is that, just speaking from my experience working in the crisis unit, many calls that we receive about youth are from, schools or, other kind of entities that have some resources to support youth in place. And so when they're calling us, it's kind of when a situation has exceeded their ability to manage and they're looking for a crisis partner to, help them safety plan that youth or help them access other services. And I think we have pretty good relationships with those youth serving entities. I could speculate that people might be a little less likely to call 911 about a youth versus another resource where, not in any way to suggest that we have, plethora of, plenty of services for youth, but I do think there's a little bit, in some ways, a little bit more substantive resources for youth in our community.
Okay. And then the next question, I'm curious about the trauma-informed approach of CARES when they first respond to a call. How do they establish safety and comfort of a person in need without overwhelming the patient? And I'll start with just saying that, the clothes they're wearing, the type of vehicle they're in are just some of the superficial things. But, the crisis workers have been already trained in this world of, how to de-escalate and how to approach a scene. But our paramedics, they get a certain amount of training just in their baseline paramedic training. But we sent our paramedics through crisis intervention training through NAMI, that 40-hour course. We put them through a 17-hour course at UW Green Bay for crisis intervention and have done a lot of work just with the police department around de-escalation. So, I mean, this is the point of what we're doing, right? This whole program, in my opinion, is about being, having this trauma-informed approach and making sure that when we walk in, we're not escalating scenes, right? And so I don't know if Sarah or anybody else has anything to add, but this is the point of our team, right? Having a non-law enforcement response.
I also think that what that looks like on a call-to-call basis is one of our big challenges is that we just don't know what we don't know. And oftentimes we don't know the person that we're speaking with. So I think it's fair to say that across the team, we're very transparent about who we are and why we're at their front doorstep. And as much as possible, letting that person drive the bus, to what extent do they want to talk to us? What would they like to get from our conversation? If it is one of those more acute situations where we're feeling like we need to exercise a little more influence to make sure someone is safe, then like giving as many options as possible within, what we think might be safe for them. And those are really general things, but it is tricky because the specifics of like what might be triggering to one person versus another, I think we're all kind of like feeling that out gradually as the call is progressing as well.
And I'd like to add too that the 911 center puts all of the call notes, so the conversation basically with the person that 911 is having, they put those notes in a computer that is in the vehicle with the workers so they can kind of see what the person has said before they get there. And Journey has the ability to look in their EHR to see if that person has been in the Journey record before. And if they have, that's very helpful, right? They can see the person's care plan and possibly see a better path forward. And also the 911 center lets the person know that CARES is coming, right? They say, hey, there's a non-law enforcement response coming with a crisis worker and a paramedic. So we hope that alleviates some anxiety as well before they even get there.
And for community partnership, when the CARES comes, they get on the level of the individual that they're speaking to. So someone's sitting, they sit down right next to them. They ask first, they ask if they can join their space and if it's okay to talk to them. They speak in a very a soft tone to not escalate. Then if someone's on the floor, they will sit down right next to them on the floor so that they come into their space so that the individual doesn't feel intimidated, but that someone's over them. They do only come in pairs. So it's not like 5 police officers responding at once. It's just 2 people and they let them talk and they listen to them before they figure out what the next steps are. And that is a very, very great aspect of this CARES unit.
Thank you, Carla. So the next question, Sarah, I'm going to give this one to you. Can you speak more to how you partner with MPD's mental health unit?
So, I mean, there's definitely, collaboration that's occurring because, many times some of the folks that CARES and the mental health unit are responding to, there's a lot of overlap. So like one thing that we did just, because information is so key. We've already kind of talked about this a little bit, like information that comes up in the dispatch notes and things like that, information that Olivia and the other crisis workers can access in our EHR that can help inform their contact. For some individuals who are often in mental health crisis and generating a lot of emergency response, the Madison Police Department Mental Health Unit has created a mental health bulletin about them. So it's just kind of a one-page snapshot that just, will say like what their hooks and triggers are, what's the plan for emergency response, who to call in an emergency, meaning like who are their support people. And we updated the MOU between Journey and the police department to allow, and the fire department to allow those bulletins, which are normally for law enforcement only, to be shared with CARES as well, so that they have access to that information. So it's, things like that, that are really just about information sharing in a way that helps, ensure the best possible outcomes on these calls. And I'm sure Steve and Olivia could speak a little more specifically to how you might collaborate with our law enforcement partners as well.
And I'll just jump in real quick and say that I think the biggest difference is that CARES is really truly a 911 response from the get-go, where mental health officers aren't often the first people to respond to a mental health crisis. When behavioral health crises are given to law enforcement because CARES is not in service or because CARES is on other calls and not available, it's a patrol officer. It's not a mental health officer going to the house. So, I mean, I think that's the other big difference is that those mental health officers get kind of integrated into the call at a later time, possibly for resources and things, but CARES is truly that like first people walking through the door response. And I don't, are we good? I'll move on to the next one. We got quite a few questions, so I'll keep pressing forward here, but will they be having certified peer support specialists with lived experiences on the crisis team or as part of the crisis team? And so this is a great question. We get it quite often. I can speak to when we talked with San Francisco. San Francisco has a 3-person team, and one of those people on their team is a peer support specialist. We haven't been able to kind of cross that bridge, if you will, for a number of reasons in our community. Number one, it's a budget thing. Number two, we couldn't really, in our particular program, couldn't really figure out how to get the right peer specialist at the right time, right? So we could, because we're going on such a variation of calls. So what we do try to do, and I'll let the team speak to this better because I don't do it daily, but we do try to involve peer support when it's needed, right? Like Journey can work with safe communities and say, hey, we've got this person that could use a peer support specialist, and then they can connect them. Is that fair, Sarah and Steve? Everybody? Okay. But yes, that's a great point, and we do understand the benefit that the peer support specialists bring to the table on these types of calls. We just have limited resources to pay for them to be on staff with us constantly. Do you work with or respond to youth? And if so, what does that response look like? I think we kind of already answered that question. So I'm going to, for the sake of time, pass by that one. And then do you have an...
Just ask sorry, just like a housekeeping question here. Maybe this is a question for Angela. There's a lot of the questions that have been answered in the Q&A. And I'm wondering, just like the slides are going to be shared with participants at the end, if there's a way to share those typed answers with participants. I would imagine it might be hard to be kind of like trying to read those while listening to the discussion. And I want to make sure everyone has access to the information.
Yeah, that's a really good question. I don't know the answer. One thing I'm thinking, because this is being recorded and the recording will be posted, I'm wondering if there's a way that the Q&A also gets posted, and I just don't know. Anna Marie, do you happen to know the answer to that?
I don't, but I could figure it out for us. So
okay, we'll try to get that answer before we wrap up. We'll do our best.
Okay.
And if we're not able to get that answer and we get to the point where we've answered all the questions and some of them were answered written in the chat, maybe we could even go through and read them so people can at least hear them and have all the information.
For sure.
Thank you. Go ahead.
All right, so the next one, do you have an estimate of how many of your patients have a dual diagnosis of behavioral health and intellectual developmental disability? And are there special considerations when responding to this population?
Ché, can you remind me if that's one of the data points that's collected? I don't believe we have a field in our EHR to, to indicate that.
No, it's intellectual and developmental disabilities. They would need to be put in our data in the form of that being like a primary impression or a diagnosis from the Journey Mental Health Record. So I think that this is possibly a hard one for us to answer. What our folks are doing is dealing with the situation as it is and trying to find the right resources. So if they recognize that somebody has a developmental disability, hopefully they're walking down the correct path to help that person. I don't know if Steve or Olivia have anything to add to that.
Yeah, I would say with this population involving caretakers is really important. They're going to know the patient the most. So if we can build trust and collaborate with them to find the right solution, right resources, that's going to be the best outcome.
Thank you, Steve. Next question. Do you maintain data on veteran status? We do. And then it says, when you work with veterans and if eligible, do they get transferred to the local VA for services? And yes, they do. That's the best place for them sometimes. And especially they will request it. But yes, in our demographics that we capture, we do gather veteran status. And the VA here is a great resource. So it said, I believe you mentioned that a large amount of the clients that you interact with are taken to the emergency room. Do you have any more information about those ER visits, such as what was done and if that person received the care needed? Do you follow up on those cases? And so the follow-up is dependent on the problem, but I can say, and I don't know, Journey might have a better answer for this, but I can say that we don't always get information back from hospitals. Like the fire department, when we take patients there in our ambulances, we don't automatically get information back on what the outcome or the prognosis was for the patients that we drop off. So that is a little bit more complicated. If we work directly with, if the patient is working with a social worker and we have, contact with the social worker, we can, do some follow-up, but it's very individual, I guess is what I'm going to say. Does anybody else have more clarity on that?
Maybe Steve and Olivia could talk about the process of when you bring a person to the ER, how you hand off their care.
Yeah, as the paramedic, when we go to the ER, I'm going to try to advocate for our patient to the nurse, the receiving nurse in the ER. Just try to educate them on what resources we provide and what they could possibly need in the future. And a lot of times, the crisis worker and myself will go talk with the social worker in the ER and re-explain the call and also what services this patient may need and what may benefit them.
I think it's also important to acknowledge that, we would like to minimize taking patients to the ER when that's unnecessary. And I think a lot of times police take people to an emergency room because that just seems like the better place to assist them than, a police officer assisting them perhaps. But we recognize that an emergency room isn't always the best place for people to receive the support they need for a behavioral health crisis, but sometimes it is. And sometimes they need a higher level of care. And the way our system works in the Madison area is that almost every psych admission is done through an ER where a patient has to get medically cleared and all of that. It's a whole process. And so I just like to point out that for every patient that CARES is bringing to an emergency room, they have exhausted efforts or options to resolve the call in another way, whether it's because the person's needs are so acute that they need inpatient level of care, or it may be in some situations, perhaps the CARES team is feeling like, I kind of feel like we could safety plan this person or meet their needs in the community, but the patient wants to go to the emergency room and they have the right to do that. And then in the cases where CARES is transporting a person to an emergency room, given that previously all of those calls would have gone to law enforcement, every time CARES takes someone to a hospital, that's someone who is not delivered to the behavioral health care that they need via a law enforcement transport. So I think I just like to highlight all of those positives about even when an ER transport occurs.
Thank you. Next question, is there any plan to expand this program outside of Dane County? And I can say that will probably never happen, our particular program, because we fall under Dane County Human Services. And like I mentioned earlier, each county has the authority to oversee programs. So, we've had a lot of questions about if we're going to expand outside of the city of Madison into the county. And those conversations are still happening. There's about 35 different EMS agencies in Dane County, and not many of those agencies can't provide community paramedics because they're volunteer departments or they just don't have the budgets. And so can the city of Madison provide care for the county? Well, that would be up to the county to provide us funding to do that. We can hire more workers on the Journey side and on the Madison Fire Department side, and we can stage them around the county if we were given facilities. But this all gets into very deep budget talks. But we are talking with the county about what expansion would look like. Do you have a plan to provide all law enforcement with this training? It seems like it would benefit the first responder entering an unknown situation. So to provide all law enforcement with this training, I don't know which training, I guess, specifically that you're talking about, but we've talked with, in the city of Madison, we don't just have the Madison Police Department, right? We have the UW Police, the Capitol Police, Shorewood Police, and right, all these little communities inside of us that we cover, and we work with them to make sure that they know CARES resources are available to them. But as far as the training goes, I don't know specifically what they're alluding to about the training.
I don't know if it's like CIT training that's being put on, but that would be up to each department's staff to determine if that would be appropriate for them or not.
And I know that obviously City of Madison Police and UW Police do, and Capitol Police. I've talked with them, and they've had CIT as well, if that's what they meant. Can you speak more about the follow-up after CARES team sees someone? Steve or Olivia, do you want to?
Yeah, because we're a 911 response service, it's difficult to provide kind of wraparound care after the fact because we're continuously responding to these 911 calls. However, if there is a patient that we've had multiple contacts with that we want to continue to support, we will try to reach out to them, try to advocate them with their services that they have in place or help them access services. But to just say a CARES team is going to do a follow-up on this patient after one incident, that's pretty difficult for us to do. So that's the important part of us connecting the patient and doing a warm handoff with their services, so that way they receive those services down the road.
And I think, Steve, you just kind of answered this next question a little bit, but I'm going to read it anyway. So when completing these crisis response calls, are you noticing that there are other crises that the individual may be going through? For example, housing instability, exacerbation of physical health issues, food insecurity, et cetera. And if so, are you providing resources for the other crisis? Do you follow up with a person so that it does not potentially cause another behavioral health relapse? And I think Steve just kind of spoke with that. We'll provide resources to get them somewhere where hopefully they can manage their co-occurring issues, right, or the other issues they have. But when we do see people multiple times, we do follow-ups with them and try to provide as many resources as we humanly can. Does that sound fair, Steve and Sarah?
Well, and I was also going to suggest maybe Carla could speak to this a little bit, because I think one of the things that happens is that because CARES is so often responding to places like, the Beacon and the shelters and stuff, and or delivering patients to other community partners like Off the Square Club, or, being in those spaces, that I think there's a familiarity that comes. So even though this isn't so much related to like direct follow-up with an individual post a call for service, but more just the community presence and the developing relationships and developing trust with the community that I think happens when they're in spaces like Off the Square Club.
Yes. So you're absolutely right. The CARES usually comes to Off the Square Club once a week. And has lunch with our members. So they have built a network of individuals with a mental health diagnosis that get the services, quote unquote, that they need from the cares just by their presence. They're able to de-escalate when the cares is around because they know that they are safe people and that they will help them if they, I will call 911 and I will request the cares team before I request an officer to come. And then they can do the wraparound there because they're members. So they'll stop in and they'll be able to be like, how are you doing? How are you feeling? What's going good for you? What's working? Also with the wraparound, I know the downtown unit, if they find an individual that doesn't have resources, they will bring them to me. And then I am able to connect to the different services that the cares cannot. And then we can work as a community to help an individual become whole.
Thank you. How do you deal with client confidentiality when sharing bulletins between agencies? And this is the reason it took us a year to get through all the planning and get a team on the streets. And we have a lot of conversations with our attorneys, but it's all HIPAA business agreements and contracts and making sure everything is above board. It's continuation of care. So everything has to be done very thoughtfully, carefully, and a lot of conversations with attorneys.
I would also add that mental health bulletins that I referred to before are created by law enforcement, which is not HIPAA protected. It's more that they just have a policy that, to keep these from being in the public, that they're only allowed to be shared within the law enforcement agency. But because we saw the value in allowing CARES to have access to that information, we made it so that they could share the bulletins with CARES. But CARES is not sharing patient records with law enforcement. They're just consulting with law enforcement on active calls as needed, or relaying safety concerns, that sort of thing.
Yeah, and even for Journey and Madison Fire to be able to share records, we have to have a HIPAA business agreement, even though they're working together shoulder to shoulder, side by side on calls. And then Sarah, I'd like you to answer this one because you have the most contact with law enforcement, but what has law enforcement's response or feedback been since CARES started?
I think that's a great question. I had a lot of concern about law enforcement feeling like, or I wondered if some law enforcement would feel like, we're trying to sort of step into their territory or sort of take calls away from them or something like that. I've literally never had a conversation with an officer who has felt that way. It's been such a resoundingly positive recognition from officers that we are not the appropriate people to respond to behavioral health crises. We need this in our community. And as I alluded to earlier about officers being often the ones who are recognizing this is a call that, that CARES could go to, and being the ones to request CARES on the radio, I think really shows that. And I've had many conversations with officers and command staff within the police department who are thrilled with the work that CARES is doing, feel like it's, just a game changer in terms of the landscape of emergency response in our community.
I would second that. I've heard nothing but positive feedback from our law enforcement partners in the field.
This question we spoke to a little bit, but does the CARES staff receive additional education or training on how to support an individual who may have a developmental disability? I'll just start out with, paramedics get training on dealing with, all types of different folks, from completely nonverbal, unambulatory patients, all the way through. But in the crisis response world, Steve spoke earlier about, working with caregivers. And I don't know that I'd have to let Sarah and Olivia speak to what Journey gets specifically around developmental disabilities, but yeah, this makes it very complicated, and caregiver or family involvement is key.
I could just jump in real quick on the paramedic side. All the paramedics on the crisis or on the CARES team are all community paramedic certified, which has its own educational requirement for us to become community paramedics. And that does involve education and training on interacting with individuals of all intellectual disabilities, chronic health conditions, things like that.
I would also add that I think, recognizing that the CARES team is designed to respond to a wide array of behavioral health emergencies. We are not a specialized unit, like we don't focus on one type of patient. And so the goal is for them to provide culturally, neurocognitively appropriate service to whomever the patient is, wherever they are. And so we've tried to provide an array of training across multiple topics, like dementia, trauma-informed care, youth needs, housing instability, all of these different things that we know that they're going to encounter and have encountered. But we also kind of recognize that we can't, if our goal is to create responders who are experts in all of those things, we'd never get a team on the street. So I don't mean that to sound dismissive. I think these are all really important issues, and we do continuous trainings. One thing I don't think we mentioned yet is that when we first hired the initial team, there was a kind of a 2.5 month gap between when they were hired and when the CARES team went into service. And they spent that time doing a lot of training and doing a lot of community networking and outreach, and really kind of learning from our partners, what partners like Carla, what do you need from us? How can we best support your consumers? And that work continues to this day. We're not able to spend as much time on it because now the teams are in service and responding to active calls. But I think that's also baked into the work that they're doing when they're responding to these different agencies, to, patients who are in different types of settings and may have different support people around them and things like that. Every rep of a call is a learning experience for them going forward.
And how many people on the team respond to a call? Is it dependent on the type of call? And no, we typically send one paramedic and one crisis worker. That is the common team. Sometimes because of staffing, the way that the staffing model works out, there might be 2 crisis workers working on that same shift, but they'll alternate calls because the crisis workers have a lot of detailed documentation to do after calls. They end up running 4 calls in a row, and then so they need to take some time to get the documentation done, so then another crisis worker can jump on. But when you see the CARES team respond, it's usually 2 people. Next one is, some collaboration was mentioned regarding individuals who may have been known to the police. Does this include the CARES team having access to police plans that have been created for individuals? And I think we spoke to that a little bit with the bulletins. So our team, the journey crisis worker and the paramedic, don't have access into the complete police department database and to all the reports that they do. But we try to share information about specific patients that CARES could be seeing with those bulletins and things like that, and in conversation. CARES sounds great and an important resource to the community. By keeping people out of inappropriate or restrictive settings, I would consider this budget friendly. Do you agree? And any data around how much money this may have saved the county? Boy, this is the question that we have the hardest time answering. How cost effective is this program? We can say things like the police department hasn't had to go on 1,780 calls, so it saves some operational stress, possibly saves some overtimes, some of that budget. But we don't charge for this service, right? We're not billing folks when we visit them with our CARES team. Our ambulances, when our ambulances transport people to an emergency room, it's a $1,200 fee, right, to their insurance company or to the individual. That's how the city can kind of generate some revenue. Well, these folks that CARES is taking care of are not going in ambulances, and we're not charging. So and to me, being a municipal employee, this isn't about money, right? This is about, I was asked to help with a team that would provide better services, better behavioral health services to our community, and that's what we're trying to do. Fortunately for me, I'm not a private business owner that has to make money on this program. So and Sarah, I don't know if you have anything else to add to that, but the finance question has been a big one. Like, where are you getting the money and how are you generating revenue?
And I think, being a part of a crisis unit, being part of the Madison Police Mental Health Unit, and being part of this team, I struggle, well, partly just because I'm a social worker. So I think like a social worker, not like a budgeter or a planner, but also because I think it's really hard to measure the interventions, the impact of the interventions that we have, because a successful crisis response may mean that a person doesn't end up in the hospital or doesn't end up in jail or doesn't end up, badly hurt or worse. So when you're trying to measure the things that you prevent, you really need large longitudinal studies to see that. And we are comparatively a very small and new team at this point. Also, when you talk about cost savings, is the question of where do you count those cost savings? So if a patient is stabilized in the community without going to an emergency department, that's could be saving the state money if they're on Medicaid. It could be saving the hospital resources if the person's uninsured. So there's lots of different entities that benefit from these effective responses.
The next one is, does your team respond to the jails? And as a 911 service, we respond to where we're called, but we try to work closely and make sure that we're being called appropriately. So Steve and Olivia, have you been to the jail? I mean, we can go to the jail. We will if they call, but.
Once or twice, I think. Oftentimes because there's an on-site mental health team at the jail, it's more appropriate for people to use their resources. But we have been.
When I'm aware of the CARES responding to the jail, it's been somebody who's in the lobby, like maybe they came into the building or they were just released. So they're technically not in the custody of the sheriff anymore. And I know CARES has responded to the jail in that way. I wouldn't imagine they would be responding to people who are currently residents in the jail because they have an in-house mental health team.
Next one, what are the challenges standing up this program and what are the current challenges you experience in the program? I'll start. The challenges were really all very administrative. At first and no disrespect to the mayor's office, but we were told, hey, fire department, hire some social workers and start going on calls with them. Like, let's get this done. And we realized very quickly that because of DHS Administrative Code 34 and the other things that are laid out, right, statutorily, we needed to work with Dane County Human Services, and we needed to make sure that we were getting all the contracts and everything in place. Luckily, there wasn't anybody that said to us, hey, this is a horrible idea and we're going to put hurdles in your way. Right. But when you come to budget talks, right, there were a lot of people saying, hey, take money from the police department and get this team up and running 24/7 right now. And that's not the intent either. Right. Like we work closely with the police department for a reason. We don't want to take from their budget. Personally, I don't want to take from their budget, but it's just really just a matter of good intergovernmental work and getting all of the lawyers to agree on what is okay and what isn't okay. This is the first time that Journey Mental Health has had people housed in a fire department, right? And so there were some initial kind of hurdles as far as, hey, we've got these new folks in a fire station. We needed to train Journey on how to use radios and what it's like to ride in a fire department SUV with lights and sirens and all those kind of little things. But those weren't really so much challenges as much as just needing to, we didn't know what we didn't know. And so we had to learn quick. Luckily, our workers are great. Our staff has been fantastic. It's actually gone a lot smoother than I thought it would. And current challenges, I just put it all around budget, us having the ability to keep our workers, right. We worry about turnover. This is hard work. These folks are not, Steve and Olivia are not being paid a lot of money. They're great employees, but boy, I could see if Olivia got offered $50,000 more to go be a social worker somewhere, she might take it. So, those challenges of just, the amount of funds that we have available to pay our folks are probably my biggest concerns, just keeping good employees. I don't know, Sarah, if you have anything else to add to that.
I'd love to hear from Steve and Olivia what you see as the challenges as the operators of the team, of the work on the.
I think the biggest challenge was kind of figuring out what we were and who we were and what we were doing initially. And then we've kind of got that figured out. And now it's more so figuring out how we build the best relationships in the community. There's so many different resources and figuring out how to get them to talk to each other. How do we talk to them? How do we provide patients these resources when they change on a weekly basis? So that's been a big challenge. But a benefit of us going through our challenges and having this program succeed is we're getting attention from other departments in other states. I believe last year we had a couple fire chiefs from St. Paul come down and talk to us because they want to start up their own program. So it's, even though there's already some programs already in the wild that are doing this, this is still really revolutionary, pairing a paramedic with a crisis worker. So for this city to really recognize that need and put it into practice is astounding.
Yeah, and as far as I know, we were the first city in the state of Wisconsin. So every state runs things differently, and so when we talk to those other cities and other states about what they were doing, they were able to do some things that we're not able to do simply because of statutes and city ordinances and other things like that. So that was another thing, is just learning what we were allowed to do in the state of Wisconsin compared to other places.
I think, and Steve definitely just spoke to this, part of the challenge is that there's this, we call the system that we're all of care and support that all of us here are part of. And oftentimes the people we see, that system hasn't taught them. And so we're interacting regularly with individuals who are experiencing like chronic homelessness or substance use disorders that they can't get a handle on, or have a moment where they're able to kind of pivot and seek that support. Chronic and persistent or severe and persistent mental illness. And it's really hard because then we're kind of in a position of trying to connect them with services that haven't worked for them in the past. And I absolutely, I'm not at all being blaming, but it's kind of like we're seeing barriers, and so it's a question of how do we personally come alongside someone and maybe lessen that barrier, and then also, as Steve said, like how can we all collectively talk to each other better to kind of catch people at various levels of challenge or difficulty.
It says earlier, we mentioned the different vehicles the CARES team has had, going from a van to an SUV. In the future, is there a plan to get transportation that is accessible, such as a van with a ramp or a lift for someone using a walker or a wheelchair? And it's a great question. And the issue again is budget. Like the fire department has these SUVs, right? That's part of our fleet. We looked into getting like Sprinter vans and larger vans so we could do more consultations inside the vehicle, right? A lot of these other programs have those kind of large Sprinter van type vans. And it wasn't budgetarily reasonable for us to do. We just couldn't purchase those vans. And the other thing is if we do have somebody that's in a wheelchair, we've got city vans accessible to us that we can call for those resources. And so for the small population of people that we do see that need a ramp for a wheelchair or a walker, we can get that resource to us to transport them. I mean, even somebody that is obese and maybe doesn't fit in the back of our vehicle, we can get other transport resources for them. But yeah, it's a budget thing. We would love to have huge vans that we could, right now on a day like today, to be standing out on the street trying to help somebody is not going to help them, right? We need to get them into a warm space. And I wish we had, $2 million more to buy a bunch of these really nice big vans, but it just isn't happening for us. How closely does this mimic other response teams like this across the country? Are you able to speak more to those that haven't been around longer and their success? We started out in our planning phase, like I mentioned, researching a lot, any other program we could find. We specifically wanted to find programs that were fire-based so that they were similar to the fire department, working with crisis workers, because a lot of these kind of co-responder programs, it can be a law enforcement working with crisis workers, and it can also be like a private entity working, hiring paramedics and working with paramedics. But yeah, I mean, when we look at their annual reports, we look at their data, we look at the call types that are going on, it's all very similar to what we're doing. For instance, the STAR program and Cahoots, they see about 20 to 25% check welfare calls. And we didn't realize that was something that was going to be part of our call volume when we first started doing this. But because we saw these other programs doing them, we said, hey, rather than sending police on check welfare, we can do it as well. And it ended up that over half of those patients that we see on check welfare calls ended up having some sort of behavioral health or mental health component to them. So, you know, it was just basically us stealing all of the work they were doing and implementing what we could here that we're allowed to do. But yeah, I mean, as far as success goes, that's another question that we have a hard time answering. What does success mean, right? Like, does it mean that we're seeing a ton of patients? Maybe not. Does it matter what happens with the patient after we see them? That's probably success, right? But it depends on who you talk to. The police department would say it's success because they're not going on 1,700 calls anymore. You know, we consider success obviously based in a very patient-centered way. You know, are our people getting help? Are we seeing the same person over and over again? And things of that nature. But yeah, I mean, I might be being optimistic, but I think in the time that we've been in service, I would consider our program a success on many different levels. And in comparison with those other successful programs, we look similar. Is there discussion of using the expansion of CARES to move toward police abolition? No, not at all. The police department, in my opinion, and again, this is a personal opinion, the law enforcement has a role in our community, and we're not trying to take resources from them. We're trying to add resources to all of the protective services to make our responses to the community more appropriate. You say you don't want to take from the police budget. Why not? When you're doing that work that they were previously doing, doesn't it make logical sense for you to receive funding they were previously receiving? I made that statement personally because of the fact that I appreciate the work that the police department's doing. I don't think that we've made taking 1,700 of the, you know, however many thousands of calls that they've gone on, in my opinion, doesn't mean that we need to start taking a bunch of money from the police department. Now, in 5 years, if we recognize that we've made a huge dent in the operations of the police, you know, we can have these conversations. I'm just saying that, to me, I believe that the City of Madison Police Department does damn good work. And I don't want to take away from, taking money from them would only hurt their ability to do good work. Nobody's perfect. I don't want to get into a political discussion, but I just personally don't want to see our program taking things away from the police. We're too small right now.
I would just add that I think it's about a larger discussion about where we put our resources as a community and a society. And so we really don't look at it as like a zero-sum game of like, we take this money from here and we put it over here. We value as a community that there is a better response that we can give to people in a behavioral health crisis than law enforcement. And as we've been talking about throughout this presentation, we started very small intentionally, and we're growing slowly intentionally because we want to make sure that everything we do is informed by the data that we're collecting and what is best for our patients, and you know, our ability to recruit and retain staff, and you know, all of the infrastructure that goes around supporting a team like this. So the goal of CARES is to better serve patients. The goal is not to, you know, abolish or defund or anything the police. If we are successful as a team in providing better service to people who are in a behavioral health crisis and reducing our community's reliance on law enforcement for behavioral health crises, that is a win. And that may in the long term lead to some shifting of resources. So I just wanted to put that kind of spin on the conversation. Thank you.
Yeah, thank you. Do you have any statistics on racial breakdown of people served? You know, the people served in general, of those brought to the hospital, of those where law enforcement was called in. So yes, absolutely. We collect as much demographic data as possible. And we've got, and I'm going to, it brings up a good question. I'm going to email our first year's annual report to Angela so she can get that annual report out to the group. And it has a lot more statistics about the demographics of people that we saw. Sarah, correct me if I'm wrong, but we've only had is it still 2 arrests that have occurred after CARES saw somebody that was only, like, we've given 3% of our patients to law enforcement for protective custody type issues, but I think we've still only seen 2 or maybe possibly 3 actual arrests.
So when there's a call that's transferred to police, the person who's running data for us sends every one of those to me to look at and see what was the actual outcome of that when the patient was transferred to police custody. And yes, most of them have been transports to hospitals or transports to detox for patients who needed to be in those places for their safety and were not willing or able to go with CARES to those facilities. And I did not come prepared, but I want to say you're right that it's been 2 or 3 calls or individuals, not 2 or 3%,
Yeah.
but number like 2 or 3 of people who have ended up being arrested at the result of their call.
What our data right now can tell us is of the patients that were brought to the hospital, what was the exact demographic breakdown of those patients specifically. We get a lot of really good data back so we get it from 3 places. We get it from the Madison Fire Department patient care report, Journey, EHR, and the Dane County 911 Center, as far as how many calls they've given us and the time on scene and all of that stuff. So we do have demographics, but we don't break it down specifically to like each outcome and what are the demographics inside of each outcome. It's just a lot of data mining and data analysis that's difficult for us.
I'm going to jump in if I might.
Yeah.
Sorry to interrupt, Ché. So we have about 4 minutes left. I have a couple of announcements here at the end, so maybe just time for one more question.
You got it. We have 4 left. So other than getting a higher budget, what policy changes would you like to see to improve the CARES program? I'll start by saying that, and there was a question earlier about the mental health triage center that the county is in the process of budgeting and funding right now. I think the elephant in the room for us is that we don't have a resource, a 24/7 resource to take people to other than the emergency room. So when this Dane County mental health triage center opens up and it's a 24/7 facility, brick and mortar right here in Dane County that we can take people to, then that will give us more incentive to open up 24/7 responses overnight. So that we have, and it's just going to be a better place, right? So we just need more assistance with resources. Dane County is very resource rich, but there's not enough, right? We have limited beds, we have limited times a day for resources. So those are the things, in my opinion, that could help.
Great. Thank you so much. Many thanks to all of our panelists for sharing their time, their expertise, and this wonderful information about this strong program in our community. We did learn that we unfortunately we won't be able to post the Q&A, the written Q&A on our conference website, but the recording will be posted with a transcript. So all the questions that were responded to verbally, at least, will be included in that transcript. Thank you to everyone in attendance for being a part of this event and for your commitment to and efforts to confront racial injustice. Please watch for an email with a link to complete an evaluation of today's conference, including this panel. Also watch for a separate email regarding CEUs for those of you that requested them when you registered. Again, those will come out in emails and in the next couple of days. And finally, we hope that you'll join us for our closing plenary provided by Imani Barbarin of Crutches and Spice. That starts at 2 p.m. You can access the link for that plenary from the Eventbrite page. So take a quick break and we hope you come back for more great content with Imani Barbarin. Thanks again to our panelists.